Hello, my name is Dr. Gareth Weston and welcome to my fertility channel. I'm a fertility specialist who has been practising in the city of Melbourne for over 20 years and have practices also in the western suburbs of Melbourne and in rural Gippsland. In this channel, we seek to explore very specific problems with fertility treatment and with IVF treatment. And in this episode, we're talking about egg maturity. You've just had an egg collection. Your doctor calls you and says, "We got 10 eggs, but I'm sorry, they were all immature and we have no eggs available to create embryos." This news would be devastating for every patient. But what percentage of the eggs should we be aiming to be mature? What is the process of egg maturity? What are the potential causes of high levels of immature eggs? And what are some of the solutions? Well, let's walk through this together today. The number of eggs that we're expecting to be mature or that we should be aiming for should be 80 to 85% or more. If you have a higher proportion of immature eggs than that, then we have a problem and we need to be looking at solutions should you need another IVF cycle. When we look at egg maturity, there are 3 phases of maturity that we observe in eggs that are collected in the IVF cycle. The first and the most immature is a germinal vesicle. The oocyte or the egg cell will still have a visible nucleus, and this egg is completely immature and has no chance of maturing in culture and will not be able to be used. It cannot be fertilized, it will not create an embryo. The second level of maturity is metaphase 1. This is a stage in the cell division process when the oocyte is dropping down in numbers of chromosomes from 46, the number that are in a normal cell, down to 23 in preparation to receive 23 chromosomes from the sperm to create a unique individual. This is vital because if we don't have that cell division that drops the number of chromosomes, we will not be able to have a healthy embryo and will not be able to create a baby. Metaphase 1 is where the oocyte has not completely divided and still has 46 chromosomes and therefore is not able to be fertilized in a healthy way by a sperm. The final stage of maturity and the eggs that we can actually use are metaphase 2 or M2 eggs. These eggs will have a small polar body, which is a small piece of tissue or cell that's extruded from the oocyte or that's ejected from the oocyte, which carries the half of the chromosomes that are being ejected from the cell. That egg is mature and that egg is able to be fertilized. Some of the metaphase 1 or M1 eggs, if left in culture for 3 or 4 hours, will actually become an M2 or a mature egg and be able to be used. But not all, and the fertilization rates of those eggs that have been late to mature will be lower than the ones that are M2 or fully mature at the time they are collected. When I say that we're looking at more than 85% of the eggs to be mature, we need to bear in mind that we're expecting mature eggs only from the larger follicles greater than 10 millimeters in diameter. A lot of doctors will collect the eggs not only from the larger follicles, but from the smaller follicles. And we would expect that a larger proportion of the eggs from small follicles will be immature. So when we're using that percentage, 80 or 85%, mature eggs, I would prefer to look at the number of larger follicles and then determine what percentage of eggs that are mature we have relative to the larger follicle numbers. So when we're deriving that test to work out if we have a true egg maturity problem, I'm really more interested in if we've had mature eggs from the larger follicles. So what are some of the patient factors that affect egg maturity? First of all, we have egg quality. poorer egg quality will result in a larger number of immature eggs. This can be related to patient age. Sometimes some of these factors can be ameliorated through the use of adjuvants. These are treatments that are added to the IVF protocol to try to improve the quality of the eggs. A second patient factor, which is fairly rare, but we do see it on the odd occasion, is a patient who has a genetic resistance to the ovulation trigger, which triggers maturity of the egg. Very, very difficult to treat. A lot of these patients will end up needing to accept high levels of immature eggs and therefore lower chances of success per cycle. Some may even need to achieve pregnancies with donor eggs. The third issue is a patient who may lack LH. That's the second hormone from the brain, which is very important for inducing maturity of the egg and the ovulation signal. There are some patients who have conditions where they lack LH, and we need to add a little bit of LH or luteinizing hormone to their treatment protocol. This can be added in the form of either LH or luteinizing hormone or HCG, the pregnancy hormone, which is similar structure to the LH and therefore able to affect the same change. When we look at cycle management and ways in which we can improve the number and levels of maturity of eggs, we can look at the dose of the trigger and increase the dose of the trigger if we have had inadequate maturity in a previous cycle. We can change from a lighter trigger to a stronger trigger, so from a drug called decapeptyl to recombinant HCG or pregnancy hormone. We can also look at triggering the maturity of the eggs in the IVF cycle by letting the follicles grow larger. If we let them grow out from the 17 millimetres when we normally trigger through to a 23 millimetre follicle, we may be more likely to get larger numbers of mature eggs. Furthermore, when we collect the eggs, we can leave them in culture for 1 or 2 hours longer than normal in order to try to increase the maturity of the eggs. We can also have a slightly longer delay between the onset of the trigger and the time when we collect the eggs, but we can't go more than 1 or 2 hours beyond the expected egg collection time, because when you give the trigger, if you leave it too long, the patient will ovulate and lose all of the eggs. And finally, we can try giving a double trigger, which is giving what I would call a lighter and a heavier trigger together, usually given 1 hour apart. So I hope this helps you to understand what egg maturity is, what the levels of egg maturity you should aim for in an IVF cycle, what some of the problems that cause high levels of egg immaturity are, and what some of the solutions are with cycle management to improve the situation. If you found the information that I've imparted today of interest, please subscribe to my channel. Please share it with your friends if you have friends that think they may benefit from the information we've gone through today. Thank you for listening.